Hello, everyone, and welcome to the Berkeley Public Health Research Seminar. I hope you all had good spring breaks and got rested up because the rest of the semester is a bit of a sprint from here. So we'll all need our energy to draw on to make it over the finish line. So I'm really pleased to introduce our speaker today, Yan Long. She's an assistant professor in sociology at UC Berkeley, and she's a political and organizational sociologist who studies interactions between globalization and authoritarian health politics. She has a forthcoming book, Authoritarian Absorption, the Transnational Unmaking and Making of AIDS Politics in China, that looks at the impact of transnational organizations on the formation of China's public health institutions over a long period between 1978 and 2018. And so today she'll be speaking with us about fixing digital health apparatus, local government's COVID-19 vaccine promotion on the front line in urban China. So thank you so much. I can't wait to hear your talk.
Thank you so very much for this opportunity. Okay, so let me share my screen first. Okay. Here we are. Do I need to narrow the screen or anything? No, it's go. Okay.
It looks good.
Okay. So I really appreciate this opportunity to share some of our very exploratory analysis we are still developing about the COVID-19 responses in China. So first of all, let me highlight my collaborator, Professor Wei Luo, who cannot be here today because this is 3 a.m. in Beijing right now. And secondly, I cannot emphasize enough how our findings are very preliminary. So we absolutely welcome any suggestion and critique. Okay, so this is a picture of people getting tested for COVID in China. So this was really a regular day for most Chinese for the past 3 years. So during the pandemic, the Chinese government had directly monitored individual activities with far greater rigor than what most other countries could ever imagine. So we tend to portray the COVID control measures in China as a simple story of coercion. In particular, people tend to emphasize how the government's enormous administrative enforcement power and information collection capacities through digital technology. So this is the kind of image of everything, everywhere, all at one state at its finest, with a very top-down, coherent institutional framework. However, given this image, many might find the vaccination challenge in China quite puzzling. So November last year, right before the country was about to open up, about 90% of Chinese were vaccinated. However, around 30% of people aged 60 and up, or roughly 80 million people, were not vaccinated and boosted. Among those 80 or older, the ratio was closer to 60%. So the image was completely flipped in the United States, if you think about it. So 80% of Americans received their first dose, I think roughly about the same time. 68% was fully vaccinated, but over 80% of those aged 65 and older were fully vaccinated. So here comes the question. The 90% of oral vaccination rate might not seem surprising because people are just simply going to say, hey, because of coercion, okay, Chinese government can make their people to do whatever. However, if it's a simple story of coercion, why don't we see the same result of coercion among elders? Although we cannot fully answer this question today, our goal for today's presentation is to provide a different perspective to think about this question of vaccination beyond just authoritarian sort of regime and the political coercion. So, vaccine programs have long been considered a very critical measure to combat infectious disease, but they have encountered many waves of doubt and oppositions ever since the mid-19th century. The World Health Organization accordingly defined vaccine hesitancy as, quote, delay in acceptance or refusal of vaccine despite availability of vaccine service, unquote, which has been particularly evident during the recent outbreaks of, for example, measles, H1N1, and COVID-19. So despite of the rise of vaccine hesitancy in recent years, however, there are also many people who are willing to accept and prioritize vaccinations. So many scholars have, there's just a gigantic volume of literature dedicated to vaccine acceptance and hesitancy. And most scholars have predominantly focused on identifying social, demographic, psychological, or various experience-related personal predictors of very favorable or unfavorable belief and attitude towards vaccine. And more recently, medical sociologists have emphasized the relational mechanism, such as effects of online and offline relationships and communities, and some highlights the impact of neighborhood and spatial factors. However, the analytical focus has always remained largely on individuals as the primary agents for health behavior and risk assessments. Getting vaccinated or not is seen as a knowledge-based individual rational decision. So despite of the growing recognition of vaccination as a significant political issue in many countries, sociologists have ignored the state role in shaping both vaccine hesitancy and acceptance. Personal ideology stance and trust in governments are often considered as the only relevant factors, reducing the political context to a very limited number of individual level factors. Especially lacking is the research on people's interactions with government authorities around the vaccine as a political context. Meanwhile, public health scholars have documented various national strategies such as information and education campaigns, mandatory vaccine certification, financial and non-financial incentives, access facilitation, such as providing transportation, etc. Those analyses tend to focus on the national level while looking at the design of formal policy tools and strategies, which paint a picture of very coherent vaccine campaigns in each nation states. We ask a very different question. So how do local governments agencies actually mobilize people and cope with vaccine hesitancy in implementing national vaccine policies? We highlight the ways in which those formal tools and strategies unfold in government organizations' everyday practices on the local level, and how they shape residents' vaccination behaviors. So the battle against the vaccine hesitancy and the promotion of vaccine acceptance do not take place in the abstract realm of policy crafting, but really in the routine action of frontline public employees charged with policy implementation tasks. The national government's requirements for raising vaccine coverage are always universal. However, day to day, whether and how frontline workers embrace or evade those requirements really varies by the ways in which they respond to the conflicting demands from the government and the neighborhoods they serve. So, let me see. So contrary to the conventional wisdom that the government must be unifying the strong supporters of vaccination, our analysis leverages organizational literature on street-level bureaucracy to demonstrate how local level administrative units can exert different degrees of tolerance and intolerance and even encouragement of vaccine hesitancy. In particular, we argue that digital instruments do not automatically bolster the state power, but they might actually help local bureaucrats to exercise more discretion and control. So before I demonstrate our findings in empirical details, let me first tell you a bit about our research methods. Okay, so our research site is Shenzhen. It's a city north of Hong Kong with a population of 12.8 million and a GDP of almost 500 billion in 2022. In case you wonder what that means, it means this young city with only 40 years of history had already surpassed Hong Kong's economic development altogether. Its urban government has heavily invested in information communication technologies and digital infrastructure to attract foreign indirect investment and present the city as this very advanced urban economic, cultural, and social space. So home to technology giants like Huawei and Tencent, they're probably more famous. Shenzhen has transformed itself from the world factory represented by Foxconn. Foxconn is still there, but it's not as significant now, to Asia's Silicon Valley. It's a very, very young, it's a very, very young city. And house code, even though many people think it was invented in Hangzhou, but Shenzhen was actually, they had their own new version of house code probably 3 days later. So it was very proactive during the whole pandemic. So like how to win, like how to surpass other cities, how to do a good job is very, very important for them. So my collaborator and I have been doing research in Shenzhen for almost 5 years now. Between 2018 and 2020, we were studying its civic life, including doing more than 250 interviews. I actually have not spoken to that many people in depth in the city of Berkeley so far. So we really know the place really well. So just to give you some idea about the pandemic, okay, this is the data from last November. Things have drastically changed since China had opened up, but I don't have access to reliable data at this point. So just have some sense. Between Shenzhen, San Francisco, and Los Angeles. So you can see Shenzhen is gigantic. It's pretty much I would say it's comparable to the Bay Area. For our international comparative research is a comparison between the San Francisco Bay Area and Shenzhen. Okay, so it's large. But its COVID cases were under 10,000 and the deaths were only 8. Those were probably accurate. People always have doubt about different data, but I would say even among all Chinese cities, Shenzhen was considered as really the model city that has done much better than Beijing and Shanghai or Guangzhou. Okay, so this is to give you some sense. Okay, this city has done really well. It was aggressive, it's competitive, it's important for them. The anti-pandemic measures were really important, the political task for the municipal governments. Okay, so in terms of the sampling, we chose to focus on the neighborhood unit, or what we call 社区. It is the lowest government presence in Chinese cities. And we chose to focus on social workers since they're the classic street level bureaucrats. Okay, according to the definition, street level bureaucrats would include such as teachers, police officers, social workers, public lawyers, and other court officials. So that is the definition we follow. And we also wanted to have a group of people who are professionally trained and certified. Because across different neighborhoods, we wanted to gain some reliability in terms of our measurement. So this is to give you some sense about the neighborhood community. Above it, it has the district, the sub-district or street level. And then you have the district government, then you have the municipal government. Okay, so to give you some sense about the scale, the neighborhood community, the unit usually manage about between 50,000 to 100,000 people. So it's like a small town. Actually, not a small town. I think Berkeley is about that size in the United States. So that's the scale of the street level. Well, it is a community level. Yeah, the neighborhood level, community level, that's the scale. So for each frontline workers, they're usually in charge of about 3,000 to 5,000 residents. Okay, so that's their sort of jurisdiction. Okay, so we also chose social worker because we wanted to avoid the political controversy. COVID measures were extremely sensitive in China, so it was a very difficult study. So we chose theoretical sampling to conduct the face-to-face in-depth interviews with 50 social workers as frontline public employees for the government. So the sample is not generalizable. I don't think so. So our goal is really to generate theoretical hypothesis to be tested by other people. And in our sample, we have agents from 19 agents from medium to high income neighborhoods. It's called as 小区. Then you have the hybrid communities. It covers both, like they have a mixture of migrant workers as well as local residents. There are 15 of them. Then we have 16 agents from urban villages, what they call just villages or 村. This is important because Shenzhen is a migrant city. 63% of their residents are migrants without local household registration. So when I say local resident, I'm referring to the 37% of the local residents with household registration, which means they have much better access to the welfare benefits and so on. They're enjoying full citizenship. Okay, I can talk more about the sort of the method problems because this is a really challenging topic to manage if you're curious during Q&A. Okay, so here comes analysis. So when people think about zero COVID policy and digital tools, we are thinking about like Star Wars, okay? We're thinking about in a room with multiple screens, you can see everybody moving and you can see all the movement. Okay, but in reality, digital tools and their utilization is extremely messy, fragmented, decentralized, basically chaotic. So when it comes to vaccine, given the time limitation, I'm just going to give you some sense about how chaotic it actually is. So there are multiple units who are vaccinating people simultaneously. And then there are several data management systems. As you can see, those are different platforms, okay, working at the same time. There are actually more than those 5 listed here. So one individual could have multiple vaccine records in different platforms, but those data sets were never integrated. In fact, even within one platform, there were multiple unintegrated data sets. So they're really extremely difficult to use. As one officer commented, quote, because the third dose need to take 6 months apart, many people have already forgotten which entrance they used or which platform they used 6 months ago. Every time I ask someone, do you remember what did you do? It's like I have to redo their whole personal information for them. So I generally do not recommend people to use certain platform. But if you go to, for example, if you go to community health center for vaccination, the doctor there will definitely recommend you to use their platform, because they also have their quotas and they need new clients, but I don't think that's a good idea, quote. So while there are different platforms horizontally, frontline workers also have to cope with tasks assigned vertically from their superiors. So in theory, on the ground, they need to gather and directly report household data to the district level government through a centralized platform, supposedly. The data were then analyzed at the district level big data center before being dispatched to lower level units for specific objectives, such as which population to target. However, mistakes in this process it's a very long chain of information transport, and the mistakes are just happen all the time. As one officer said, quote, people who have already been vaccinated are labeled incorrectly. The data are never ever updated. So people always got annoyed when I call them about the list. They would say, I have already got the vaccine. Why are you still calling me every day? So even when frontline workers reported the mistakes, they were not corrected. So leading to increased frustration and the challenges for those working on the ground. So here comes the problem. On the one hand, you have this tool from the government, which doesn't really work very well. On the other hand, you have insane pressure also from the government in terms of improving the coverage. So there were specific quotas for each frontline workers and their units to achieve every day. For example, there would be usually it's about 5 people per day, but they need to make, for example, 100 to 200 phone calls. That would be their task and the quotas they need to meet. Okay, so the question is, how do you manage all this chaos? Okay, so people usually think the local governments in China, they have one image, which is excessive coercion, or what Chinese would call 层层加码. Even outside China, people think the governments always take one stand, which is to encourage vaccination. However, what we found is that the government at the neighborhood unit level, different units and frontline workers can exert very different degrees of mobilization strategies and different degrees of tolerance and intolerance towards vaccine hesitancy. The first type is what we call overzealous one. They focus on mobilizing down to every individual resident to boost the vaccine coverage within their own neighborhood. So there were about 38% of agents in our sample account for that. I don't think the percentage really make much sense, but just to have some idea. And then the second one is the passive accommodation. This type of neighborhood responses generally aligned with the top-down vaccine campaign. However, they don't strictly pursue every unvaccinated individual. The measures adopted tend to be more performative. The absence of enthusiasm and commitment to top-down vaccine campaigns lead to accommodation of hesitant residents, whether intentionally or unintentionally. So there are about 56% of agents would fall in that category. Then you have the active accommodation or resistant ones. Well, many frontline workers would question the vaccine and the legitimacy of their mobilization approach. A few actually tried to actively accommodate the vaccine hesitant individuals, even in the face of the insane pressure from their superiors. So there are about 8% of agents would fall in this category. So let me go through them one by one. Okay, so direct coercion with the first one, the overzealous mobilization. The direct coercion usually involves a task force responsible for scanning the building, which means they would go door to door and investigate the residents' vaccine status and persuade them to get vaccinated. Usually when people refuse to do it or they come up with reasons like medical reasons, the medical professionals would be then brought in to conduct on-site health examination for those who had concerns. And then if still it didn't work, the police officers would be called in to apply pressure on the resistant individuals. So mobilization measures can be extra aggressive in migrant-dominant neighborhoods. As one officer told us, they actually, since they have already set up the blockage around the village to control entrance and exit points beginning in June 2021. So community workers would check residents' vaccination status and then, quote, send unvaccinated ones directly to a car to get the shots, quote. A common approach is for frontline workers to take turns visiting each household in the area to encourage vaccination, particularly targeting seniors. So this is a quote to give you some sense about what they would do. Okay, so they would go to their homes, they would talk to them, they would schedule a home visit for them to receive the shots in their house, even on weekend, without receiving any overtime pay. This is one of the things people criticize China all the time, but when you work on the ground with those people, you're like, holy shit, you work really hard. Okay, given the time limits, so I'm just gonna go through the post really fast. But then even with overzealous mobilization, some of the approach tend to be much more indirect and softer. So they tend to invest a considerable amount of emotional labor in persuading individuals and addressing barriers in the vaccination process. So it is a very typical approach I'm showing you on the screen. Is we tirelessly knock down doors, encourage individuals to think about vaccination, we emphasize their benefits. This was especially important for seniors. And then they would also organize transportation for them. They also did this kind of follow-up check after the vaccination process to make sure that they would get the second shot, the third shot, and so on. And to persuade the residents, the social workers would appeal to their sense of responsibility toward their families and the public, especially in the less wealthy neighborhoods. They would tell individuals, for example, quote, this benefits your family. If you get infected, you put your full family in danger, quote. They would also emphasize how this is really a sense of responsibility towards your community, towards the country. Very interestingly, they didn't talk much about the benefits or the danger of the vaccine, because as one said, quote, we don't know. We ourselves cannot be sure about the safety of vaccine, to be honest, quote. So the key point was really about the targeted persuasion. And some of the frontline workers would go very, very far in terms of creating this kind of personal profile of each person who refused to take vaccine. They would have very dedicated, targeted strategy in order to persuade them. So they spend a lot of time. They also spend a lot of time trying to fix the digital apps problems. For example, since the big data center constantly make mistakes, so frontline workers would strive to correct those mistakes by entering and uploading vast amount of data manually. We learned that sometimes information about the vaccine recipients were recorded on paper, and then Excel table was used to capture data such as names, gender, student ID, and why they declined to get vaccinated, and so much. One interviewee remarked, quote, you have to use your fastest speed at absolute full attention to input one entry in a few seconds. Otherwise, you cannot just get it done, quote. So they did a lot of sort of work to fix the digital tools. Then you have the passive accommodation ones. So those are the most fascinating ones, in my opinion. So passive accommodation means that frontline workers used more performative measures. They didn't genuinely aim at achieving full coverage within their own neighborhoods. as the government would intend it. They did not apply strong pressure to vaccine hesitant individuals, and they mainly saw their job as disseminating vaccination related information and engage in performative mobilization efforts. So basically what I think happening here, it was the same as really performative, because they know it's not targeted, it's just, it doesn't work. So contrary to overzealous mobilizers, this group of workers would really emphasize how to look like they were doing a lot of work. They would carry their loudspeakers around the neighborhood, shouting various slogans. Okay, I'm working here. Does it work? No, but I'm working here. You can see as this quote, they emphasize communication about understanding, and they did a lot of work of reporting. Okay, if this person doesn't want to get vaccinated, instead of pressuring them, they would just report back. Okay, for whatever reason, they didn't want to get the shot, and that was it. So unlike the overzealous mobilizers, when people ask, like, I have medical reasons, this group of people would not bring in the health professionals. They would just take the words. So that's the main thing, is just to signal the commitment without really doing the job. As one described, quote, their job is to mainly focus on mobilizing, advocating, and offering guidance, quote, rather than mandating vaccination. So that is a key difference. Well, my time is really limited, so I'm going to skip a lot of details. But if you're interested, I can always talk about it later. So for this group, the frontline workers were much more sensitive about what the side effects of vaccine might entail to them. So they would ask the seniors to sign liability waiver if they want to get vaccinated. As you can see, that really scared away a lot of seniors. And for them, since they cannot really fixing the problem of apps, they would exploit the digital chaos on the ground. They would not update the list of dispatch from the big data center, and they would do the bare minimum in the complex and the disorganized data reporting chains without going beyond those tasks. And this is to give you some sense about it. Okay. But so how do they even fulfill their quota? So in those wealthy neighborhoods, what we found is that instead of targeting and pressuring their own residents, the frontline workers would go out of their neighborhoods and go to less wealthy areas, and then to persuade their residents to get shots. Okay, so this to give you some sense. The first one is about they just bunk down on the street, and they would attract the people with like cooking oils, various material incentives. And in some cases, they would even snatch passerby on the street by offering various just better gifts than their neighboring areas. Quote, there's something not on the slides. We're giving them laundry detergent, 2 bottles. The head of the neighborhood committee pressured us, assigning us a quota of 5 people. To meet the quota, we need to do everything. So we started to offering like 500 yuan, which is about a little bit under $100 US. So one interview is from our urban village neighborhood shared, quote, there were intense competition among neighborhood units and the street to come to us and recruit our people. So if you offered 500, I would offer to 700. If you give 700, I give 1,000, 2,000, or even 3,000, which is about $500 US. So even people from other provinces who got vaccinated in our neighborhood would count towards our quota. So that's what matters. We don't really care about the individual quotas, but this is very important for us to help our boss not to lose face. Quote. Okay, so this even happens. So that also the pros on the screen to tell you they would go everywhere else to fetch seniors to convince them, mostly the poor ones who can be lured by money. An interviewee actually recounted her experience attempting to locate unvaccinated individuals in the urban village that was outside her assigned service area. Quote, we encountered people from other neighborhoods all covering on that one spot. When the security guard learned about our intentions, he simply said, all finished, everybody got vaccinated, no one left, just leave, quote. Okay, so the third type, which is active accommodation. Given the limited time, since I really want to get to the Q&A, I would just highlight one frontline workers. So she was stationed in a very small community, consisting mainly of retired professionals. So she had this sentiment, quote, we understand that vaccination should ultimately be a personal choice, but we still have to encourage them repeatedly to push them to get vaccinated. When you make 100 calls, there would be 100 different reasons for not wanting to get vaccinated. I actually don't not bother collecting this data. This is no use, but I do remember the legitimate reasons people give, such as pregnancy or feeling unwell or high blood pressure. This is the thing, high blood pressure for many officials were considered as a ban. It's like you cannot get vaccinated if you have high blood pressure. So the next time when I call someone, I try to pick up a few of the most common legitimate reasons and ask them directly, such as, is it because you feel unwell these days? The person then would confirm, yes, yes, yes. So they would give this kind of leading questions to help the seniors to get away from the vaccination efforts. Okay, just a very few seconds, a few minutes, I want to talk about how to account for those kind of variation. So we found that we are mainly focusing on two factors accounting for the neighborhood diverse strategies in mobilization. Okay, one I had already alluded to, which is the neighborhood compositions. Neighborhood with a substantial population of migrant workers tend to adopt much more aggressive mobilization efforts. Several frontline workers stationed in those neighborhoods share the similar opinions about very different attitudes between migrant population and affluent residents. One described, quote, people in urban villages are much more approachable, whereas those in apartment complexes are often more difficult. In other words, urban villages are just easier to manage. So as residential communities with many renters, they're very cooperative. And another explained that, quote, urban village residents often have more burden. Consider why they chose to live in urban villages. Because it's cheap. Many live paycheck to paycheck and have numerous children to feed. They just want this whole situation to end as soon as possible, quote. So compared to more aggressive sort of comprehensive vaccine mobilization efforts in those areas, mature neighborhoods with like high-end residential sort of areas generally experience more accommodating measures. And this gives you some sense about mostly if you pressure back, okay, rich people and people with high educations, they were the most troublesome to deal with. So guess what? Frontline workers were not going to push. So the power dynamics between frontline workers and the wealthy senior residents are very intricate. I want to give you one example. So in a very upscale residential community with a significant senior population, a frontline workers recounted how her working on vaccine mobilizations was just really difficult. She said, quote, our elderly here know how to take care of themselves. When you have substantial wealth, you are pickier than regarding the medical resource that you enjoy, the quality of medical services you require. Our elderly people are quite proactive because they pay close attention to their health. Therefore, they are extremely cautious about the safety of vaccines. You cannot convince them to get vaccinated using other methods as long as they think there is even the slightest risk involved. I'm not saying they won't get vaccinated, but they have more options. They have their own family doctors who give them advice. I don't have medical training. Why would they listen to me? Quote. Okay. So aside from different power dynamics, the community bureaucrats, the bureaucrat alignment is another major factors that would account for different mobilizing strategies. To just in a very simplified way, usually when frontline workers were much more aligned with the government, with the bureau, if they thought of it as their professional sort of identity, they would go out of their way using their mobilizing skills and their relationship and the connections with the community to fulfill the quota. So they always have this kind of social trust with residents, which can be utilized. However, for those who were aligned with the community, they either see this professional identity as just siding with the clients, which were the residents. Then they would actively sort of fall back or take a much more passive approach. And some frontline workers would see this whole anti-epidemic measures as just a disruption to their professional identity altogether. They thought instead of doing all this nonsense vaccination, what they should have been doing should be focusing on their own work. So feeling frustrated with vaccination campaigns, then they took a much more passive approach to just fulfill to maintain the appearance of doing the work rather than really doing it. And I do not have time to go through all my quotes, which I really love. Okay, so just some very preliminary conclusions. Basically here, what we're discovering is three things. One is the variations in how local campaigns will promote vaccine acceptance and the battle against hesitancy. They're variations. Secondly, digital technologies need extensive support from frontline government workers whose willingness to fix those tools actually vary. Third, frontline workers can deliberately or intentionally accommodate certain populations' vaccine hesitancy, but not others. And implications. The first one is about the vaccination. We really need to rethink about the knowledge-based individual decisions. People got vaccinated it's very contextualized. It was a lot of decisions right on the spot. It wasn't necessarily a decision. It was driven by all kinds of reasons, such as emotions, relations, other dynamics. And information campaigns, dissemination of informations actually doesn't work that well. Secondly, we are trying to promote the idea that we really need to bring the state back into the discussion in order to understand people's health risk assessment and their behaviors. And then thirdly, we want to emphasize the paradoxical effects of digital technology. As we're looking at the AI at everything, people always talk about how scary it might be. But I think that there is definitely space because guess what? Technology needs human labor and they cannot live without us. With that, thank you very much. And let's see. Yeah, I'll just stop there.
Great. Thank you. Thank you so much. It's so interesting, that really interesting data, and contextualizing it is just great. And I'm going to open it up to questions or comments. If people want to either unmute or raise your hand or put a question in the chat, I'd be happy to take those now. Jen, and then Monica.
Hi, Yan. Thanks so much for that talk. It was super interesting to understand the local variation and sort of the governmental response. I wondered if you could return to the beginning where you noted that there was the least vaccination as people got older and older, and just sort of how does that fit in with this, and why was there particularly resistant group among older ages, or is that just about wealth? Anyway, any thoughts you have on that?
Okay, I cannot speak to why elders want to have more sort of resistance against it. I actually don't think that's the case, because a lot of research and survey of people's perception and attitude toward the vaccine conducted in China actually have not identified a severe or like starker sort of resistance among the elders. So what I'm trying to tell here is that it's not so much about people's attitude, but to what extent their hesitancy or their oppositions can be tolerated by the state. I think that's the key thing I wanted to get at. So going back to why seniors, I think in this city, so first of all, is that there is definitely the lack of confidence among bureaucrats in terms of the safety of vaccine. That's very obvious. So from the very beginning, because the Sinovac did not go through clinical trial among people older than 60. Then even so at the beginning, the government was very nervous about it. But then even later, when it was corrected, local governments were still hesitant, was still very nervous about the safety. And for many local agents, it's not so much about the effectiveness of vaccine. That was not their concern. Okay, so keep this in mind. In China, people were heavily relying on lockdowns, okay, segregation, instead of vaccine to maintain the safety. So the local government, for them, for lots of the agents, is more about things should not go wrong. And I do not want to take the blame when things go wrong. So that's why even in 2022, when it was already confirmed that high blood pressure should not be an obstacle, it was many community level frontline workers were still using it as a line to say, okay, don't get vaccinated. If you must, sign a waiver. So that was, in that sense, the interaction itself between the seniors and the government had contributed to the misinformation, contributed to the resistance, and so on. Then the second one is definitely the wealth. As you can imagine, if the government was focusing on the migrant population, which is very young, we're talking about a labor pool, okay? They were young. They were not the wealthy kind who can afford the housing in Shenzhen. Shenzhen housing is more expensive than the Bay Area. Okay, so it's not cheap. So as you can see, I don't think it's so much of wealthy people don't want to get vaccinated in China. I cannot say that, but I would say their hesitance and anything they feel like uneasy about it, they got more power to push back. That's what I can say is as a result. But attitude level, I cannot really comment on that. Yeah.
Thank you. Monica, did you want to ask your question? And then Dan Yang.
Sure. I have two questions. Thank you so much for the talk. It's very in-depth. My first question will be on passive accommodation. I'm just wondering, what does the government do to cope with that kind of passive accommodation of the frontline worker? And the second question would be like, what's your perspective on the forceful wave vaccination in China and the more like chill back, like voluntarily kind of vaccination way in America? Like what's the different perspective that you approach the pros and cons of those two different ways of approaching things?
Okay, the first one, so the passive one, okay, this is what we found is that the government pressure was pretty universal across different units. However, as you can, so there was insane competition, and the government actually, the municipal government would publish the data from different community, the neighborhood units. So you are ranked. Okay, as you can imagine, you're ranked at the street level, at the municipal level. However, the fascinating part is that the pressure didn't really, they account for some of the behavior, but on the ground, they were very active resistance in terms of, okay, how do we do our job? One of the things about the digital chaos that I didn't have much time to talk about is that because of the difficulty of communicating the data, there are many ways to explain away the discrepancy or the low coverage. Because in reality, if the frontline workers didn't update the list, the superior, the higher level government never get a sense of who actually are not vaccinated and who are vaccinated. So that's the beauty of it. If you use the digital tool to monitor your agents, they can also in turn utilize the gaps to do their job. So that is the thing. But so in terms of the pressure, isn't so much, I think, aside from the pressure, is really their own identification with the government. And also if the unit leaders, they make a huge difference. Many people would feel, many frontline workers feel like they were not working for the government per se, but they love their leaders so much. They feel like part of this group, part of this bureaucracy. They just wanted to win. They want to see good performance. Okay, so it's not so much of the pressure, but it also gives you some sense for Chinese government to really achieve the goal it wants. It really needs insane amount of pressure, like on a daily basis. It's very costly. It's extremely costly. So our research, we have other papers on, for example, the mandatory COVID testing. That's a completely different story, okay? Because that's just like, you cannot, I mean, Shenzhen was the one who invented the 24-hour vaccination every day. They were the one who first practiced it and was like, okay, we can do it. Then other cities began to follow this insane model. Okay, so that's a very different story of political pressure that just account for a lot of the results. Okay, so in terms of which way is better, okay, I would say, okay, so first of all, it's not like Chinese are just like being forced to take vaccination. No. Here, as you can see, there are a lot of persuasion, a lot of relational, like emotional work went into it. And what I didn't talk about is a lot of young people were volunteering. Like they were just doing it out of their choice. There is no doubt about it. So I don't think that I think this is so much of a difference. I think in every country, you always have to have populations who are just more pro-vaccine. However, in terms of what the government is doing, I don't want you to see as just coercion, because a lot of the things the frontline workers were doing, such as providing vaccination shots right at the seniors' home, for example, providing like the whole transport, not just the transportation, but really being there for them along the whole way, the whole process. Okay, such as really establishing this kind of, they did a lot of survey on their own to figure out in their neighborhood who is not getting vaccinated for what reason. Those kind of targeted, that kind of attention, I still do think those are something that the United States can learn from. It's like, I don't think just a message like blast or social media, that kind of thing really work. It just, I think the US need to do more. China needed to be chill. So come to a middle ground. But I definitely think there are more things that government could do just in terms of promoting vaccine. And also I think the whole process really matters. A lot of frontline workers in my research actually talk about this kind of, if you just buy people, for example, like kind of incentive, or if you coerce them to do it, the problem is they would develop even more negative emotions against the vaccine in the future. So they were very worried about the third one, the fourth booster, and so on. So I think this whole interaction with the health agents really would make a huge difference, even for people who are opposing. I think if they got a good sort of relationship out of it, or they have good interactions, I think that can help them to, to like vaccine a little bit more next time.
Thank you so much. Thank you so much.
Thank you. We have time for one more question. Dan Yang.
Yeah, hi, Ian. I think the strategies that you identified is really important and interesting to me. And I'm pretty convinced by the whole motivation and also potential two explanations. Well, I have one question, which is before you explain your own explanations of those two factors that are influencing the strategies that frontline workers are utilizing, I'm actually thinking about potentially other factors, since you mentioned the importance of government, the state, the organization, and also digital tools in your theoretical motivation. So I'm thinking during your discussion is the role of local bureaucracy, like the level above those frontline workers, how they are making decisions, making policies, and deciding what the frontline workers will do. How do they recruit those workers? From my own experiences, I think some workers with or without healthcare or medical expertise might make a difference. And are they incentivized by those policies and their leaders? And another potential way is that do these local bureaucracies make different decisions or utilize differently on those digital tools as you established? Is there a way that they organize the workers and the data has an influence on the way the workers behave and the work are recepted among the community?
That's a very good point. I think obviously we haven't talked about alternative explanations since we haven't decided on the theoretical framework yet. But I can speak to some of the comments you make. So I guess one of the things I really want to emphasize, I don't have time to demonstrate, is that during the whole pandemic, it was chaotic. It was it's dreadful, it's draining. It was 14 to 16 hours of work every day. There wasn't so much of policy making per se, when everybody was just scrambling. Okay, there was scrambling to just stay afloat. That's actually one of the biggest challenge in my research, is like everybody was so tired. It's difficult to conduct like interviews when they can't even remember. So a lot of the things they were doing was very practical. It was improvised. I really want to emphasize that there's a lot of improvisation. So in terms of the digital development, actually during the pandemic, in 3 years, Shenzhen had developed at least 6 versions of health code. So they have been updating the version. They were trying to make it better. They were trying to integrate the data set. absolutely, there are a lot of problems that was on the higher level in terms of why can't they just integrate the data set, and also in terms of the data sharing, there were a lot of bureaucratic obstacles. So that didn't. I think it's difficult to explain that. It's just anti-COVID measures were extremely pricey, was extremely taxing. And it didn't leave a lot of room for like regular discussion about incentivizing and so on. It's more of the inaction and the process. I think that's some of the things I want to emphasize is, yes, this is, I would say the relational work, the sort of improvisation and how to people were learning. I think the frontline workers were learning about how to live with digital technology. And to what extent, in what ways they could accommodate it. Okay, I think that's what everybody was trying to figure out. But of course, I do think the policy feedback later in terms of the instrument development, that would be something fascinating to just keep watching and see. But I think one of the lessons in this is that it's just not sustainable. I just don't see any possibility for them to sustain this. The mandatory COVID testing was even crazier and much more expensive. It's just financially, fiscally, it's not possible. So I mean, the China model it's an experiment. It's an experiment. I'm not so sure how it's going to affect its later. Yeah. I hope I answered your question. Yeah.
Yeah, thank you. Thank you so much. I see that we're at time. So thank you so much again, Yan, for presenting your work and sharing with us. I really, really appreciate it. And good luck with the rest of your work. And thanks everyone for joining, and have a good day.
Thank you very much.
Thank you. Thanks so much. Bye-bye.
Bye.